Hi friends, today I will talk about the Winter ECG sign, which is though infrequent, but it is an emergency if it is detected in ECG. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer the diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only, and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for the diagnosis, treatment, and prevention of medical illnesses. There is no endorsement for any brand or a company. The deep winter ECG pattern, it is an infrequent presentation. When it is present, it is highly suggestive of occlusion of left anterior descending artery, that is acute occlusion. The ECG finding, they are consisting of ST segment upsloping depression at the J point, and that is depression may be 1 to 3 mm in leads V1 to V6, and it is often associated with tall peaked positive T waves. This phenomenon or sign is seen in 2 to 3.4% of the patients with anterior MI, and the risk factors are same as that of ischemic heart disease, like increased age, smoking, dyslipidemia, hypertension, diabetes, and obesity. It was first reported by Dutch Professor of Cardiology Robbert J. Winter in 2008. And this Winter ECG pattern, it is an anterior ST elevation in MI equivalent, and this is present without obvious ST segment elevation. When it is present, it is suggestive that patient is suffering from occlusive myocardial infarction and may require immediate reperfusion therapy. The diagnostic criteria for this deep winter phenomena is tall, prominent symmetrical T waves in the precordial leads, upsloping ST segment depression, that is more than 1 mm at the J point in the precordial leads, absence of ST elevation in the precordial leads, reciprocal ST segment elevation 0.5 to 1 mm in AVR, and typical STEMI morphology may precede or follow the De Winter pattern. The clinical significance is this is seen in 2% of the acute LAD occlusion, and it is often under recognized by the clinician. The key diagnostic features are ST depression and peak T waves in precordial leads, and most of the physicians are unaware of this high risk ECG pattern, and because of their unfamiliarity, it may lead to delay in appropriate treatment, that is reperfusion, and which, if left undiagnosed or untreated, may lead to increased morbidity and mortality. These are the few examples. Here we can see upsloping ST segment depression, ST depression in precordial leads at J point, peaked anterior T waves V2 to V6 with ascending limb of the T wave commencing below the isoelectric baseline, and subtle ST elevation in AVR. If I zoom it, let us see in the AVR we can see slight ST elevation, and in precordial leads we can see upsloping ST depressions in the precordial leads. This is another example. Here we can see upsloping ST depression in the precordial leads, peaked anterior T waves V2 to V6 with ascending limb of the T wave commencing below the axis, and subtle ST elevation in AVR more than 0.5 mm. Whenever we see this ECG findings in the ECG, we must do cardiac biomarker, especially the high sensitive cardiac troponin. Though this may be normal in some patients or mildly elevated initially, but it should not delay the reperfusion therapy. Since high tall T wave can be seen in serum this hyperkalemia. We must also do serum potassium level, though this should not also delay the reperfusion therapy. Differential diagnoses are hyperkalemia and tachycardia. In hyperkalemia, this can be this condition can be differentiated by its presentation, and T waves in hyperkalemia are narrow and sharply peaked. And tachycardia can also be associated with upsloping ST depression of the ST segment, and patient may have troponin T level elevations. So, based on the clinical features, risk factors, and the ECG pattern, we should have high suspicion of LAD artery occlusion, and emergent consultation with cardiologist should be undertaken, and uh, patient should be referred earlier to the centers where the cardiac catheterization or PCI facility is available, and we have to follow the guidelines as per the STEMI. We should always load the patients with aspirin, P2Y12 inhibitors like clopidogrel and anticoagulant, as we do it for other MI cases. With this, I conclude my today's topic. The best doctor in the world are Dr. Wright, Dr. Quiet, and Dr. Merriman. It was said by John Swift. Please keep learning. Thank you very much.